Good afternoon, everyone. This is a webcast sponsored by HeartLung.AI in collaboration with SCCT, and I'm pleased to have a distinguished panel comprising leading cardiovascular and lung cancer screening researchers and practitioners who are early adopters in the field. So with that introduction of the title and the focus, which is on this screen, we will be sharing with you the work that we have done in the past few years in collaboration with our co-investigators under AI-CVD consortium from various academic institutions that brought us to this point where we are ready to share the introduction of the next generation of calcium scoring in the era of AI, in particular here, AI-CAC and AI-CVD. We are delighted that Dr. Arthur Agatston, whose name is on the calcium scoring technique, is part of our panel, and he's been, in fact, an active participant in our research meetings and contributed to development of this new presentation. Without further ado, I'd like to invite panel members to please unmute and introduce themselves. On the right side on my screen is Dr. Claudia Henschke, and then we go down with Dr. Agatston. Claudia?
Yes, I'm a professor of radiology. First of all, wonderful to be here. And I'm a professor of radiology and started lung cancer screening together with my colleague, David Yankelevitz. And we were very interested in reporting ordinal scores from as soon as we could on every low-dose CT scan of the lungs.
Thank you. Arthur?
Arthur Agatston, practicing cardiologist, professor of medicine at Florida International University, and been very active and interested in this, and good to see old friends and new friends. The early work we did a lot with John Rumberger and Nathan Wong. We called it the Calcium Club, and Mort joined a little bit later.
Yes, I'm a late arriver. Thank you, Arthur. We're going down. Tony?
Good day. My name's Tony Reeves. I'm a professor in electrical computer engineering at Cornell University, and I've been working on image analysis methods, both for lung and heart, for many years, and I look forward to seeing how this particular venture plays out. It's very exciting to be involved.
Thank you, Tony. Next, Nathan.
Hi, everyone. I'm Nathan Wong. I'm a cardiovascular epidemiologist and professor and director of the Heart Disease Prevention Program at the Mary and Steve Wen Cardiovascular Division of University of California, Irvine. And I've been very involved, like several of the rest of you, and have enjoyed doing some of the pioneering work in coronary calcium along with Dr. Agatston and Dr. Rumberger and others over the decades. And I'm very excited to see these new developments with AI-CVD and how it can really take us to the next level in preventive cardiology.
Thanks, Nathan. John?
Yeah, hi, this is John Osborne from Dallas, Texas, the founder of Clear Cardio, a preventative cardiology program, which leverages now for 25 years cardiac CT for early diagnosis of cardiovascular disease, and really excited to see how cardiovascular CT has evolved to be a multimodality tool of detection.
Thank you, John. The other John Rumberger.
Hello, I'm John Rumberger. I've been a fan of this for many years. Arthur Agatston and I sort of started together this back in the Calcium Club days, and I was responsible for doing a lot of the pathologic validation work for coronary artery calcification. I continued to be that. I'm a former professor at the Mayo Clinic, and now I'm a director of Corazon Imaging, medical director and chief science officer along the way. And I'm excited to see all of this development, especially as I have personally also gotten into the artificial intelligence situation. And this is just very, very exciting. Thank you.
Thank you, John. Tom?
Hi, I'm Tom Atlas, private practice radiologist based in Tustin, California. My specialty is body imaging, but I also do a significant number of the lung cancer screening and the coronary artery calcium type scans. So it's just is part of the general practice I'm in.
Thanks, Tom. David?
Hi, David Yankelevitz. I'm a radiologist over at Mount Sinai Hospital here in New York City. Along with Claudia, we actually started low-dose CT screening for lung cancer back in 1992. I am not a member of the Calcium Club, and however, I followed their work very closely, and Claudia and I became so interested in it that we introduced it into low-dose CT screening, where we developed an ordinal score and have been continuing to work on calcium scoring introduced into lung cancer screening since then, and seen all the amazing progress that's been made.
Thanks, David. We're happy that you and Claudia and Tom from the non-cardiology world are part of this. And this is going to be an exciting venture. This is just the beginning, and we hope that this collaboration between multidisciplinary diseases, lung cancer screening, emphysema, COPD, cardiovascular disease, and cardiometabolic and kidney will bring AI will bring all of them together under the umbrella of a chest CT. And that's the project that we're developing towards, and we'll be having a separate symposium at American Heart Association's conference in New Orleans in a few weeks. Without further ado, I'd like to invite our chief engineer, Dr. Anthony Reeves, who, as he said, professor at Cornell University, to walk us through the technical aspects of what Agatston 2.0 AI-CAC is, how it is different than the legacy Agatston score, and how it moves the field forward by addressing the issues that were identified in the original scoring technique. Then I will add additional lights on each of the components of AICVD. As you can see on this screen, AI-CAC and coronary calcification is one component, but perhaps the most important component. And then we engage our panel to talk about various cases that they have experienced and summarize our findings with regard to AICVD as the umbrella and Agatston 2.0 scoring technique and how to bring it to practice. Tony?
Yes, I'm honored to be presenting about this scoring system that has been one of the few radiological scoring systems I'm aware of that has been so widely accepted. And the goal here is to estimate the risk of calcium deposits in the coronary artery system with respect to heart disease. And I just very quickly go through the algorithm. I'm sure everyone is in the audience is aware of that. the first step is that we're on the right here, you could see several examples of different levels of the scoring system. The top left image there shows no calcium. The top right shows a single deposit of calcium in one of the coronary arteries, and that would be like a mild score as rated by 29. And then we see the two lower images with more increasing levels of calcium. The way that this algorithm works is someone with experience that can identify these calcium plaques and not get them confused with other calcium deposits that are in associated anatomy very close to, just get the ones in the coronary arteries through all the different images in this CT scan and circle them with some device and indicate that they're the ones to be scored. Then there is some minimal software that goes through, takes those areas, and then we get to the algorithm on the left for each of the areas that that person scores. And this is quite laborious. It's not much of a problem with the top two images, but if you get the bottom right image and you have to circle everything there, which is actually in the coronary arteries, it can be a little bit labor intensive. So for each of those circled regions, it is thresholded at 130 Hounsfield units, and it's made sure that each deposit is at least 1 millimeter squared, which means about 4 pixels in the typical image that this was defined for. And then in that region, we count the number of voxels that are greater than 130 and take the highest value voxel in there in step 2. And then if it's very high, we amplify its importance by that weighting scheme there. So if it's greater than 199 Hounsfield units, then it gets double the weight, and so on and so forth, up to 4 different levels there. And finally, once you have scored every one of these regions, you then sum up a total score, which is simply add them all up, and that is your CAC score. The only point I'd make that this was done in the technology of the E-beam CT scanners, which were super fast at the time, and they had a restriction of only 3 millimeter slice thickness scans. So that put one of the constraints on that remained for many years. Now all scanners have thinner slice capability, but everybody uses this still as the reference. Next slide. So I just wanted, as I'm introducing technology here, to give a bit of a context that the Agatston score was defined in 1990, which is 35 years ago, and it is still the standard today. What's changed in technology? And the answer is a lot. In CT technology, we have thin slices, iterative reconstruction, a whole bunch of new things. I'm going to cover those later. I just wanted to just touch bases on what was going on at that time. And it turns out 1990, as an example, was the first year that digital cameras came out for general use. It was the first time you could see a photograph you'd taken and before the film had to be taken and developed. So that was a great move forward in imaging. At the same year. And then 9 years later, the first cellular phone incorporated the first carrier at about 0.1 megapixels resolution. 6 years later, the iPhones came out with 2 megapixel cameras, and now the current iPhone has a 48 megapixel camera. And when you take a photograph, instead of turning all those dials, the AI inside the iPhone makes all those fancy adjustments and does an absolute brilliant job of taking that photograph for you. So that's how much that technology has changed in the 35 years that the Agatston score has not been updated. Put that in context now with AI, which is what we're using throughout the new version. And at the time that the score came up, if you had a large workstation, it might have a teraflop of power. Now, that's vastly more than you need for the Agatston score, but that was kind of the level of computational power typical of the time. In 2017, 8 years ago, NVIDIA decided we could benefit from an AI-directed GPU addition, which is in most computers today. And that boosted performance from that 1 teraflop, which is 1,000 million operations per second, by a factor of 125, one step. And now, a few years later, that, of course, we're at about 4 or 5 times that performance. And if and that with that kind of device in your small computer, you generate a little bit of heat, keep the room warm as well. But if you really want compute power, you go to a data center where with just 72 of those devices in a rack, you can be getting 1 million times more performance. And it's very hard to imagine exactly what that is, but beyond the fact that it also contributes to global warming. Final point, though, for Agatston 2.0, what I'm about to introduce, it doesn't need the super levels of power that are currently available. It can run on a laptop, which of course would have an AI GPU in it. Next slide. So here's then the basic overview of the algorithm itself. We're comparing on the left, developed by Arthur Agatston and his colleagues for 3 millimeter EBCT 35 years ago. There's the opening of their initial paper. And on the right, I'm going to be covering the AI-enabled AI-CAC score for all CT scans of the heart, basically, not just those with the EBCT or not just those with 3 millimeters. Next. The application, as I indicated, there was some manual skill required to identify the regions of interest. In recent years, there has been some updates, so in that regard, so there are now systems out there that can do this fairly automatically. On the new side, it's totally fully automated, and now the AI isn't just doing the score, but it's assisting in a lot of those things. And it started off by saying, not just the calcium, let's do all of the coronary arteries, the main coronary arteries from which the score is obtained. Next. Calibration has no calibration that was explicitly required in Agatston 1.0. But we know we're doing, and that algorithm did thresholds, so it was going to be highly dependent on how well the CT scanner was calibrated. So in Agatston 2.0, we use, if it's available, a phantom. And if we don't have a phantom, we use a surrogate for that, which in our case is subcutaneous fat. And that is calibrating not just for intensity, but also compensating for the different levels of noise that we acquire in CT scans. Next. The algorithm itself. In the original, it is something one can simply do and be sure that you get it right with an absolute minimal computer if it needs to. To calculate the maximum value is very simple spreadsheet type calculation. In our modified, we avoid using a strict threshold and increments at different levels. We just say, no, we're not going to even chop out what is considered to be the calcium. We're going to look at the whole coronary artery. We're going to do nonlinear weighting of the pixel values, and we're going to do some neighborhood operating that corresponds to saying several pixels are needed to confirm that it's a calcium entity and not just image noise. So we have the same ingredients, but we're now doing this in a generic concept test context, taking into consideration linear functions or nonlinear functions rather than the thresholds used in the original method. Next. And finally, the original scoring system provided a single CAC score as a quantifier of risk. And as we'll see today, that would be our primary output, but we can calculate other parameters as well that may give a more detailed picture of the of heart health. So with that, I'll pass on to the techniques here. The first thing is for calibration. We need to know for that scanner the calibration and intensity and the quantity of noise in the scan. And if we have a phantom, then we automatically select that region and measure the phantom characteristics. If we don't have a phantom at say around 100 Hounsfield units, then we use subcutaneous fat, which is fairly well standardized at about 90 Hounsfield units we found. And we do transform that into the range that we're interested with and calibrate it again in a similar way we do for the phantom. And that is all done automatically by AI. The AI then comes into this step that now we can, without manual help at all, identify the main coronary arteries, and we segment them out and that's the region that we actually explore. On the left, you can see the main arteries with the aorta put in there for reference. And on the right, you can see them, and they have been labeled with respect to their main names, so that if we wish, we can do individual artery analysis to do a more refined sort of evaluation of the health. So here now is how we formulate the score. On the top right, you see we start with the whole coronary artery region. We then process the pixels through an intensity transform that is calibrated by noise and intensity calibration from our phantom readings. We then go to step 3, a neighbor filtering process that gives us more noise robustness. And then finally, as with the original count, we score over all our scored readings, just sum them up. But again, in this case, we're doing it over the arteries, the whole arteries. We're not just identifying the high calcified regions when we do that summation. Next. So there has been a lot of work focused on could we not modify Agatston 1.0, and it's turned out that this is a very challenging process. If we were to say, well, it's not quite sensitive enough, how about we use 120 instead of 130? The type of study that would be involved to try and prove that would be very hard to accomplish, and it has not been accomplished. So today, 35 years later, we have not modified that, although a lot of people have done studies suggesting that modifications might give an improved score. Here's one paper that does a very good review of things that could be done to improve the standard Agatston 1.0 method. And this is by Williman in 2017. And for then, at that time, first go to thin slice reconstructions. Second, iterative reconstructions are going to give you less noise and better discernible quality. Third, now with the new scanners, you can go to a lower KVP and you can get more information about the soft plaque. And click, would you more? Yep. And now, of course, that was too early to say, but now we're in 2021. We have photon counting technology, which today is expensive, but in years to come, I would say is pretty confidently going to just simply replace the scintillation method that we currently have in use today. So more things are coming and evolving. On the right, you can see, no, go back one, please. Thank you. The figure showing the impact of different slice thickness. We're doing 1 millimeter by 1 millimeter in X and Y, but in Z, because of those initial CT scanners, we're doing 3 millimeter steps. And you can see on the left image that there are calcifications in that figure. Small calcifications only take a part of the 3 millimeter region. Larger calcifications still don't necessarily cover 3 millimeters. And if you look on the right side, what you would see if you took thin slices, then the small calcification, which on the left has essentially disappeared through averaging, is quite clear, and that even makes an appearance on the right side. So that is the obvious move to go to thinner slices there. And next slide. And this is the next image from the paper showing on the left a 3 millimeter reconstruction, on the right a 0.6 millimeter reconstruction. And it's as obvious on the right-hand image that we do have a calcification, and on the left it is below the 130, and it is too low to be scored in almost any method. So this is very well understood, and I think with our 2.0 approach, we are at last getting to address some of these. So in summary, the 2.0 AI-CAC score, Agatston, involves AI technology to identify coronary arteries automatically. So that manual step is out, and we're using the whole coronary arteries. It replaces the 130 Hounsfield cutoff with relative density units using a smoother function. It uses an AI segmented reference medium, phantoms or FAT, to adjust for noise and the calibration intensity, and it computes the relative density of all voxels of the entire coronary tree. It doesn't just focus on the highly intense calcifications. And that produces an Agatston 2.0 CAC plaque burden score that has comparable to the original Agatston score. In addition, we can now compute additional scores like the hypodensity voxels, and reports Agatston 2.0 plaque density score, as well as an overall calcium burden score. So with that,
You're on mute, Dr. Nagavi.
Sorry. Thanks, Tony. So that was a good summary of 35 years of cardiology being where Arthur Agatston and John Rumberger and Bob DeTrano started. And now we've inherited about 35 years of research and evidence. So what I'm showing is not something that I developed over the past few years, my team developed. This is sitting on the back of all those researchers who worked tirelessly over the years, including the Calcium Club, who fought to get their voice out and were not appreciated at the time. I think we're at the stage that the evidence is indisputable, and I'm just going to walk you through the clinical values or value propositions that Agatston 2.0 brings over Agatston 1.0. So we're breaking into two groups. The one advancement comes because now, as Tony said, we don't have a fixed 130 Hounsfield unit. We can go down all the way to 90 and then adjust for noise. So we have a good infrastructure to identify small plaques, semi-calcified plaques, soft plaques, whatever you call it, that were previously ignored or missed. And so we have data to show you that once we do that, we identify people who have CAC 0 and had events that were actually not CAC 0. And I'll show you the data. Then on the right side, we address the other problem that Agatston 1.0 had. So one problem is some people have events, their CAC is 0, they're usually younger than 55. And then the other problem is when we treat patients, both people who are treated and responding to treatment and those people who are not treated, both experience increased calcium score. So how do we distinguish that? Can we use CAC scoring or CAC scan for repeat scanning and monitoring response to therapy? And now with this AI-CAC Agatston 2.0, you'll see that the ratio of hyperdensity over hypodensity, because now we have relative density score, can tell you who's plaque being stabilized and actually reverses their risk. So in the CAC 0 population, let's put this one to bed first. At first, I'd like to emphasize the power of zero that Michael Blaha and Khurram Nasir and other colleagues established firmly that CAC 0 is very low risk. Even though you have a few examples and some of these presenters to start with a case example of a 50-year-old male had an event with a CAC 0, it was because that CAC 0 is because of the 3 millimeter in the original Agatston score. And now when you apply the AI-CAC, you improve on the very good power of zero that you already have. So in this case, I'm showing you multi-ethnic study of atherosclerosis cases. These are people who had events. So if you're wondering, over a period of 15 years, 80 people with CAC 0 had events, had coronary heart disease events. And this is heart events. Out of these 80, once we applied the AI-CAC, 68% of them were no longer zero. They were moved to AI-CAC greater than zero. And 25 stayed in AI-CAC. And if you focus on this range from 0 to 5, which is right here, which is what we recommend if we were to repeat calcium score in somebody who is CAC 0, you'll see we only have like 2 events. And we already know that a big chunk, maybe 5% or even more, of coronary events are not epicardial coronary related. They are microvascular coronary related. So I think with that incremental value that AI-CAC is offering, we're kind of reaching the ceiling in using CT scan to identify risk, coronary heart disease risk, based on anatomy of coronary. So I emphasize anatomy of coronary artery disease. There is not much room once you are able to detect almost everybody who had events. So that's one side of this. And that was MESA. This one is pooled MESA and Framingham Heart Study. And as you can see, it's very similar to what MESA showed us. That is, those people who had AI-CAC 0, which is green, versus those people who had AI-CAC greater than 0, have a significant difference in their risk. And the dotted blue or dashed blue in the middle is the original Agatston 1.0. This shows the same thing, that is correct at 5 years, 10 years, at 15 years. It also shows it's correct for heart events, all events, and MI. So it's consistent that AI-CAC improves on the power of zero across all categories of risk. Now we're coming to greater than CAC 0. So we addressed the problem that people refer to CAC 0, people have events, we identify them. Now we're talking about repeat CAC scans. Can we do repeat CAC scans and see who is improving or responding or who is building more plaque? And I'm going to invite Dr. Agatston to weigh in from his very long practice in this field, and he's shared with us a lot of cases that what he's referring to, these plaques age over time and become hypercalcified. And those who are getting treated, they get faster and more hypercalcification. So this graph, you see that over a period of 20 years, even adjusted by age on the right side, those who had hyperdensity or hypercalcification, their calcium is really high intensity, had less event rate compared to those who had lower density. If you put it in a 3D view, this is what you will see, that you have, around 0.3, which is 30% of hyperintensity voxels, you start seeing the risk going down. And the same thing here between AI-CAC and hyperdensity score on the left side. They show the same thing, two different angles. Here I'm going to just summarize that. In the first row in the bottom, AI-CAC 1 to 100. Remember, as Tony said, AI-CAC correlates with Agatston 1.0 in terms of the total burden. It just elaborates and provides incremental value. So 1 to 100 in ballpark is the same range as Agatston 1.0, and then 100 to 300 is intermediate and greater than 300. And I chose this because of the classifications that David Marin and Nathan Wong and Matt Budoff and others proposed for CAC-based staging. So as you can see, those people who have high CAC, greater than 300, if their hyperdensity, the ratio of hyperdensity over hypodensity, is greater than 25%, their risk significantly goes down compared to the highest group. And it's even more elaborate here. So the concept is, if you're able to use AI-CAC and report hypodensity over hyperdensity, we'll be able to evaluate response to therapy. Here is the therapy. Statin. In this group, this is MESA. On the left side, people were on a statin. On the right side, they were not on a statin. As you can see, those people who are on statin, if you follow their density, right around 30, 25, 30, 35, the risk reverses and it comes down to below the hazard ratio of 1. So that immediately conveys a protective value for increasing density, hyperdensity score. So Agatston score gives you a small soft plaque semi-calcified that are missed with the 2.0, were missed with 1.0, and then it gives you the density that changes over time, and you'll be able to monitor that. And as Tony said, we've tested it, AI-CAC, both with phantom and with fat. They have pretty good correlation, as you can see in this slide. So the summary here, I'm just going to encapsulate what Tony said and then move on to AICVD. And that is, we have moved the field forward by introducing Agatston 2.0 to further build on the 35 years of evidence that Agatston original scoring system introduced to preventive cardiology. AI-CAC can run, as Tony showed, on a thinner slice as well as on a thicker slice. In fact, all of these analyses that I've shown you from MESA were done AI-CAC on the 3 millimeter original old EBCT scans. So it shows the power of AI, that even though we don't have the high-end technologies like photon counting for our analysis, we're seeing the same value going forward. And this is moving further. Tony has not dived into it, but basically this is a real case, that's me. On the left side is a currently segmentation by AI-CAC from a non-contrast CAC scan. And on the right side, you'll see my CCTA report that I did at Harvard UCLA 2 years before. And so this is what we'll be building on. We'll be enhancing it. Again, all to build on what has already been created. We're not revolutionizing or going a whole different direction. We're incrementally adding on the Agatston score that has been around. So now, this is the beautiful part of this, the just exciting part of this, and I credit David Yankelevitz in Claudia Henschke for opening my eyes to this value, because they were preaching it in their calcium club. It's called IOCAP. And I tuned in and listened, and I was like, we should be able to bring AI and to make this available in a practical way for all. So that was 5 years ago when I met them. And now we're 5 years later at the FDA doorstep. Hopefully, when the government opens again, they will release this for patient care. That's our anticipation. So with that introduction, as you can see on this screen, we have several components. We won't have a lot of time to dive into each one of those in detail, but just know that we have published on all of these. We have close to 12 papers and 30 some abstracts submitted from a large group of people. Some of them, unfortunately, could not join here. I'm going to specifically credit David Marin from Stanford, Chief of Preventive Cardiology, and Mike McConnell, who've been very instrumental in helping us move this forward. So what are those components? As you can see at the top, we measure liver fat. A good chunk of liver is in the scan. We measure muscle density, muscle myosteatosis, which we have really exciting data to show you. And of course, body composition, visceral fat, pericardial fat, all of that. Then we report lung density, both on the low side, emphysema, and the high side, interstitial lung abnormalities. Then, of course, calcium score, we covered it. Thoracic aortic calcification and aortic valve calcification, both are part of the AICVD components. And then bone density, which was developed by Bob Detrano and his team, and then Matt Budoff significantly advanced it with tons of publication. We were happy to build on that. And then aorta and pulmonary artery sizing, again, information that is available there. And perhaps our crown jewel is what I referred to earlier. We referred to it as AI-CAC. Of course, now AI-CAC has a much more meaningful definition, but it's cardiac chambers volumetry. And to me, LVH, left ventricular hypertrophy, or enlarged chambers, LA, LV, they're similar to Agatston calcification discovery, that these are the end-organ damage done over a period of time of exposure to risk factors. In coronary, that's calcification, response to injury and healing and all that. Here, remodeling, enlarging enlarged chambers or increased thickness. So we're very pleased that we made this original. So if I were to credit our group as one real original thing with AI, again, that's also was manually referred to by Matt Budoff and folks at HNR in Hans Nixworth study in Germany at one slice level, but we've developed a volumetric report on those. So I'm just going to start with the last one. The chambers, we published this significantly. We compared it with MRI, and we demonstrated that if you just take this opportunistic finding in a CAT scan based on AI and reporting chambers volume and predicting heart failure, you do just as well as if you had done it with MRI. So bottom left is MRI. These are people in Mesa who went under both CAC and MRI scan, and I want to credit the Mesa Coordinator Center and investigators who really built the stage that we're dancing on because of their hard work. So this was very eye-opener to us. And we have a bunch of examples like this. When the CAC is 0, when AICVD risk score in this male 54 is less than 5% 10-year risk. However, if you turn on the AI light, you will see that LV volume is massive. And in this case, in a female, the same way. And both of these had heart failure and unfortunately passed away. So this is adding on that, when we compared the enlarged chamber with diabetes, so we said diabetes is currently in national guidelines as class A, stage A of heart failure. What if we compare that with enlarged chambers? And this data shows, this is a research done by my colleague, Reza Mirjalili. He is just so meticulous that was able to unravel various aspects of this for us. This paper is hopefully will be coming out soon. The nutshell message here is if you have both chambers enlarged and diabetes, you're in a worse situation. But if you have an enlarged chamber in the top 95 percentile, even if you don't have diabetes, your risk is equal or greater, like somebody who had diabetes. And then it's also further, we advance this by saying, okay, what if we just do the ratio of LV-RV? This is also Reza's paper that is coming out. And it would show that when within an individual, you don't need to know their height and weight because chambers volume are height, weight adjusted, body surface adjusted. You just divide the ratio of LV over RV, you will get a pretty good, solid predictive value. So here's LV-RV on the left side, predicting heart failure, CHF. Here's LARA, the same, and then here's LARV also. So all of those contributed to predictive value and has a pretty detailed review on those. And then this is echoing the same thing that I said before, but in two cohorts, pooled cohorts, MESA and Framingham. As you can see, the data is very consistent. As I said earlier, we refer to AI-CAC as a combination of calcium score and chambers, but at that time when we published, this is now 2 years old or so, and we showed that those people who had CAC 0 or CAC low risk had significantly enlarged chambers in height and a state of CHF risk. And that was shown both for heart failure and stroke and atrial fibrillation. So I covered chambers because, as I said, we did a lot of work there. But recently we found that if you go into the same scan and look at the myosteatosis, you actually find significant cardiometabolic risk estimate, where in this paper we showed that they predict the mean Hounsfield of muscle segmented by AI in the scan predicts heart failure and atrial fibrillation independently of the classic risk factors. That paper is coming out soon, and this is some more additional concept on that. Then we said, if you look at it further down, because Arthur will comment on that, that he and others also looked at myosteatosis and hepatosteatosis. So in this case, you'll see myosteatosis predicts heart failure and AFib. Hepatosteatosis predicts diabetes. Diabetes in healthy people who are not overweight and who are not hyperglycemic. So that's the finding that comes here. So in summary, myosteatosis is not good and is probably reflecting some level of metabolic disorder relating to insulin homeostasis in the body. We had Javier Zulueta, a distinguished pulmonologist in our team, with his help, and David and Claudia. We actually built on that and found that this myosteatosis also predicts the incidence of clinically diagnosed COPD, and we're still trying to connect the dots. Is it inflammation that everybody is a prime suspect? Is there a methodological issue here? So we're building on that. Now I'm going to pass on to my colleague, Nathan Wong, who I've been collaborating closely in the past couple of years, and we have an NIH grant application that we hope to get funded to develop what AHA did with Don Lloyd Jones and his colleagues. They really did a fantastic job of developing AICVD risk equations, pooled cohort equations, and now recently, last year, they introduced Prevent score. Phenomenal job. We're just sort of mimicking what they did, but they only did clinical risk factor based, and we're combining that with imaging and risk factor. So with that, Nathan.
Well, thank you very much, Mort. And I must first say that as a cardiovascular prevention specialist, I'm very excited about the opportunities that our cardiologists, as well as specialists in diabetes and obesity medicine, may now have to better assess and manage your patient's risk with these and a broader suite of AICVD measures that you just discussed. I think the data in particular on myosteatosis you showed is, extremely interesting and impactful. I was asked to focus on discussing some of the risk prediction stuff that we've done, and a lot of this has been focused on discussing how our AI models can better predict over existing clinical risk scoring tools for prediction of all CVD, coronary heart disease, heart failure, as well as atrial fibrillation and stroke. And so in this slide here, for example, we know that current heart failure risk prediction models really rely on traditional risk factors primarily, including the recently released Prevent risk score from the well-publicized American Heart Association's Cardio-Kidney Metabolic Syndrome Initiative. And while this Prevent, and they actually have individual scores, not just for total CVD as well as AICVD, but also heart failure. So this is probably going to be, the most important risk prediction score being recommended going forward, at least for the first few years. And while this score really, it incorporates body mass index and kidney function, which are very important predictors, our AI-CVD heart failure model, which incorporates chamber volumes as well as LV mass, in addition to other factors, can be shown here to provide significant improvement in the area under the curve for the prediction of incident heart failure. And from this, from our pooling of MESA and Framingham Heart Study offspring participants, we showed that a substantial portion of patients who experienced heart failure were actually classified as low risk by the Prevent Heart Failure score, but they were flagged as higher risk by the AICVD heart failure model. And this model really substantially improved the C statistic over the Prevent heart failure model. And what's shown at the bottom of this slide is a patient, an example of a 64-year-old man who developed heart failure 10 years later. And the Prevent risk score only predicted him to have a 3% 10-year risk of heart failure, whereas our AICVD model, which incorporates cardiac chamber, visceral fat volumes, as well as other things, including coronary and thoracic calcium measures, estimated to have a 20% 10-year risk. So this really kind of demonstrates how this model might really better identify people who are at risk, whereas our traditional risk scores, including the newer Prevent risk score, may underestimate risk. And we also showed, and I don't have a slide on this, but from our JCC paper, Journal of Cardiovascular CT paper from last year, our AICVD algorithms provided superior prediction of heart failure risk over BNP. Now, if we go to the next, that slide is here already. So in this slide here, here we're looking at atrial fibrillation risk prediction, and we can see how our model, which incorporates chamber sizes such as left atrial volumes, improves substantially prediction of atrial fibrillation over the charge AF score, which is currently often used, but of course, as we know, is limited to factors such as age, risk factors, as well as actually clinical history. Now, in the future, we plan to further validate our models by pulling several other major US NIH cohort studies, many that I've worked with over the last 30 years for predicting total cardiovascular disease, as well as the wider range of cardiometabolic outcomes that Dr. Nagavi showed earlier. And there'll be individual models that are tuned to specific outcomes. So this can really maximize the promise of personalized preventive cardiology. And while our models are currently being developed based on gated coronary calcium scans, this really has important implications and applicability for the approximately 20 million adults in the US that are annually getting non-gated CT scans for other reasons. So this really offers a tremendous opportunity to target these individuals who may be at higher risk of cardiovascular outcomes for earlier preventive efforts, who may not otherwise be actually detected, thus potentially saving many, many lives. And I'll finally just note that in a recent American Heart Association scientific statement on opportunistic testing of coronary calcium, just published last week, which I was involved with, notes that incorporating calcium scoring into routine risk assessment and leveraging AI to broaden access to coronary calcium data really holds a promise for more precise, personalized cardiovascular disease prevention. And the statement further emphasizes how these advances may enable clinicians to make better informed decisions, tailor interventions to address individuals' specific risk profiles, as well as improve outcomes at both the individual and population levels. So this use of AI to better identify and prevent disease earlier, I think is really going to become mainstream, hopefully, over the next few years. And the offerings of AI-CVD will really help move this forward. Thank you very much.
Thanks, Nathan. That was a good summary. So everybody knows Nathan has been in cardiovascular epidemiology and prevention for decades, past president of American Society of Preventive Cardiology, and he and his colleague developed a pooled cohort for diabetes. So that's where we started. I said, Nathan, let's do the same thing with image augmented model. And so we're building on his years of experience there. And as you can see, these are all is still being developed. So we're not yet, because we only have Mesa and Framingham so far. We're trying to get Cardia, Jackson Heart, Miami Heart, Dallas Heart, so we can just combine all and have the most comprehensive pooled cohort, the same way that the prevent and pooled cohort equation, AICVD, PCE has done. So with that overall background, and now that everybody is familiar with what AICVD can do, I'm going to just quickly walk you through how a report would be generated for practitioners, focusing on each of these components related to AICVD, CAC, lung, valves, aorta and pulmonary sizing, liver assessment, liver fat assessment, muscle and visceral fat assessment, pericardial fat assessment, and that the chambers that we extensively discussed. So with that, I'm going to ask Dr. Agatston, we're going back to the root, to give us a perspective of what he envisioned and what he's doing for his patients, and how he put this umbrella of cardiometabolic assessment into his perspective for practitioners. And then we'll go to other practitioners on the panel to get their insight into this. Arthur?
Yeah, Mort, this is hearing all this. This is why I first got very excited when we talked at the last SCCT meeting. And what you showed, what everybody showed today, repeats all the things I've heard and know, but I'm more excited. And starting with Tony mentioned about just the march of technology, because what we talk about and do is not just coronary calcium, but we do early detection of diabetes, measuring insulin levels, and we call the Kraft test. And we're more and more interested in atrial fibrillation because there's so much you can do to prevent future episodes. And so one of the things about all this new technology of early detection is we can follow it up in so many good ways. And predicting AFib, years ago, if you predicted it, well, how are you going to know when somebody had AFib? Now we have the loop recorders, and if somebody's really high risk, that's worth putting the loop recorder on. So you have the earliest detection, and people's first, just like the first presentation of heart disease might have been sudden death, the first presentation of having had AFib may be stroke. And it's much more common than we ever thought. So by doing that early detection is really huge. If you see by heart sizes prediction of heart failure, it's much easier than it was before to follow and see who's really on the way to that. So and the national guidelines in all these areas have been way behind the times. And because we can do so much more with prediction, all this is important. One example is it wasn't until the immunoassay where you could follow your protein hormones, insulin, thyroid. And so we know now it was really first with the immunoassay and measuring insulin levels that we can detect future future diabetes by measuring insulin levels that Dr. Kraft did in the 1970s, and with what we call the Kraft test, where you could actually measure insulin fasting, and as part of sort of a glucose tolerance test, where we can really know who's going to have future diabetes. And we do that in our office now, and it's added a lot to our practice. But again, this was all just the early using insulin levels to detect future diabetes. And if you do that, you can prevent diabetes. And the other thing that you're looking at is the fat in the liver, which you can see 20 years before diabetes is there. And this is one of the things you're going to be able to do with what you're showing. And so much is preventable with early detection. All this is particularly exciting and absolutely doable. So all these other imaging that you're showing has very important clinical clinical manifestations, and is really good. And going back to the first the early calcium score is and for coronary disease is true of preventing diabetes, atrial fib, all these other important killers, and that up and down the line, it is absolutely detectable way before we ever thought it. So it's not just the AI calcium score. I'm very proud you're calling Agatston score 2, but it's we once we have this information, we absolutely know we can prevent future diabetes, future AFib, future heart failure. It's all there and very exciting.
At
So
that time, you didn't anticipate that being such a phenomenal 35 years or so later. But were you guys driven by pathology or something? I know John was the first, John Rumberger, to show that calcium that you are seeing actually is what they found in pathology. Maybe we can hear John in a second. But when you were working on that, did you anticipate this being a surrogate marker of coronary disease?
Yes, and excuse me, what we realized is you could freeze the coronaries, and we worked with then Philip Samet, who used to do fluoroscopy on every patient to look for coronary calcium. And we did that regularly, and because of that, I knew about coronary calcium in the literature. So when he came to us, it was David came with the Imatron Corporation, and he said, this might be much more accurate at looking at coronary calcium. And what we did is we dragged a bunch of physicians in and threw them on the scanner. And it was David King and Warren Janowitz, who was a radiologist, nuclear medicine guy, and they developed the first protocol. And that's the protocol we still use. The coronary, and we look for coronary calcium. And
that is the legacy that was created 30 some years ago, and now we're building on it. I want to quickly ask John Rumberger, who was with you, Arthur, back then, and he was very vocal when I started. In fact, I learned most of my calcium scoring knowledge from John Rumberger presenting at our conference at Shape Symposia. So, John, why don't you give us your perspective where we were and where you see us going?
It's been a pleasure to work with all of these people over the years. It's really been incredibly gratifying. It's interesting that what you've now gone with AI is that you've taken the volume averaging of having a 3 millimeter slice and now made it into something that is closer to the real pathology, somewhere around 0.6 of a millimeter, or with photon counting now 0.2 of a millimeter. So if we had the foreknowledge at the time when we started to do the pathology studies to slice the heart, not at 3 mm slices, but at 0.6 mm slices, I think we would have seen many of the things that you're now showing with AI. So it's a very interesting thing. We had the 3 mm slices, and just as a side note, when we first introduced the electron beam to Johns Hopkins in the early 2000s, the radiologists, we asked them, of course, to read the lungs, and they started coming back with a lot of emphysema. And I said, no, you guys are seeing, this is a 3 mm slice. You're used to looking at 6 mm, and now you're seeing more details in the lungs than you've ever seen before. And as a result, you're overcalling what you might consider microemphysema, when in fact that's not the case. So it's really the same kind of issue along the way. We waited a very long time for this to happen. I see that this is going to be a great benefit to us using this type of screening to be able to do look at people much younger. We can look at sub-threshold calcification that we have never been able to look at before. And with all of this, it's been 35 years and we're still struggling to get the approval of the insurance company and Medicare. And that's something that's just a travesty, basically, along the way. So I applaud your efforts. I think that this is a major benefit to all of us that are in the prevention game and in the diagnostic game. And I think it's going to expand and live on the legacy that Arthur and his colleagues have built.
Thank you. His colleagues, that's you and him and many others that really carried this weight for a long time. And now we're at the stage that I think we're at the transition into a more broad, comprehensive screening. So I want to invite the two leading radiologists in our panel, Claudia Henschke and David Yankelowitz, tell us about how we can take the same thing with AI to non-gated, which Nathan Wong just referenced the paper that he's a co-author, an official statement by American Heart Association calling for opportunistic detection, early detection of various pathologies. So with that, I'll pass it on to you. Claudia, please take us to the lung board.
Well, thank you very much for the opportunity, but this is so exciting. We've been working on this, and we now, the AI-CVD gives us the possibility of working together with cardiologists and apparently also pathologists to look at disease. So we have always used very thin sections, and we're now using the sub-millimeter sections, the 0.6 and 0.2, but now you've given us an automatic way of calculating the score for coronary arteries. And before we had to make it very simple to, we developed the ordinal score, which made it very simple to calculate, but now we could really merge and work together and find all sorts of new things that we haven't discovered. And for the screening, we screen people who are asymptomatic, 50 years and older, with pack years, 20 pack years of smoking. But these are people that haven't really been explored because they have no cardiovascular disease yet. So many of the cardiovascular physicians probably don't really see them. So I applaud you, everybody for all the work, and I think the future is going to be most exciting.
Thank you so much. It's been an honor working with you and David and getting to see the entire lung cancer screening world through you and the efforts that you took early on, just like John Rumberger was ignored or Arthur Agatston's work. You guys started LDCT low dose screening and you were ignored until the big trial, the NLST trial, came out and they realized what you were saying was on point. And now we're moving the field towards the same thing on a broader scale that we'll be discussing at the American Heart Association meeting on LDCT trial. So with that, I'm going to pass it to David, who was basically Claudia's mirror in the entire research world on lung cancer screening. David?
Well, thanks, Mort. And yeah, this is really pretty spectacular stuff in terms of where we're heading. I think we're really entering, I know, Mort, you're probably too shy to say this, but we're really entering a new world or a new era of preventive health. That's what this is really ushering in. These just single, even low dose scans are going to allow us to do just so much in terms of disease prediction. This is going to become part, we think, of general health. We have other aspects of this which we didn't touch on, but when we read these scans now, the low dose scans, we always read them visually. Some of the things you could pull out visually, the ordinal calcium score, it was relatively easy, but it was also relatively crude. We could also look at osteoporosis. We could look at other things. Very hard to look at chamber size to really quantitate. It had to be really abnormal to say something. Now all of this is quantitative, and this is where this really has to go. And the types of predictions we can make in so many areas is really becoming apparent with this work. The other piece, there's two other things I want to mention. When you think of, at least in the screening world, in lung cancer screening, we have the patients coming back year after year. These are annual screens. This gives us a chance to not only evaluate at one time point, but quite literally annually. And so there's a lot of work we're going to still be able to do to further improve what we've already shown here in terms of change over time and how we're going to start incorporating this, or even make predictions as to when people need to come back for their next scan. So I think that's a very exciting part. The other piece of this is that these are spectacular long-term predictors. Cardiology especially is moving towards long-term prediction, not just 5 years, but 20 or 25 years. And Claudia just published the 25-year follow-up of coronary calcium on lung screening, and it was remarkably predictable of future overall mortality and cardiovascular mortality specifically. And it had, probably as good or better than any single biomarker for that length of time per predictor. So these imaging findings are spectacular predictors of future events. And I think this is the kind of thing where preventive health is really heading. So we're starting to incorporate all of these kind of things into our routine evaluations. And I think the field is moving rapidly in this direction.
Thanks, David. As you said, you guys were doing it manually, very tedious job as part of your research. In some other radiologists qualitatively mention calcification of aorta or valve or emphysema, but now we hope this will make it universally standardized so everybody can use this consistently and use it for monitoring changes. Now, speaking of these findings,
it's the great equalizer. It puts everybody at the same level, and that's what makes it so powerful.
that was a great way of putting it. Now, I want to emphasize on one component of this. I credit again Bob Detrano at Budoff, put a lot of efforts on this bone density. So I was at SCCT meeting last July or whatever it was, and John Osborne walked to us and he said, guys, I have an interesting case that just echoed what you guys are doing. And so that's how I got to know him. And ever since, he participated in our weekly research meeting along with Arthur and David, Claudia, and others. And so I invited John. John is a very accomplished cardiologist, preventive cardiologist, and is doing a bunch of innovative stuff under Clear Cardio. Invited him to share with us as a practitioner, as somebody who is early adopter, tell us about what that case that he had, and that's actually, I'm going to show you an example of a bone density measurement. Again, wherever the scan is, from chest, upper, lower, the AI finds and reports bone density. John, let me have you share with us your story.
Sure. Well, listen, it is such an honor and a pleasure to be amongst the founders of calcium scoring. It is, again, an honor to be presenting just some where the rubber meets the road. I think the veils are beginning to fall. I've always been fascinated by all the free data that we get from using cardiac CT. And I'm just going to illustrate a nice little case here that illustrates what we can do now. So this is a 73-year-old guy, came to us for coronary CT angiography. And interestingly, he said about 6 weeks beforehand, he had this terrible pneumonia. They pulled out 4 liters of dark fluid from his right hemithorax, et cetera. Got better. And anyway, we put him in our scanner. We're doing his cardiac CT, and we found some very interesting findings external to his coronary imaging. As we were looking at his ribs, we saw he had a healing fracture of the 6th rib, and that's about 6 weeks old. So, in fact, I saw this, and then that's when he told me the story about his quote pneumonia, where he was very sick in the hospital for a long time, and they drew out 4 liters of blood, basically dark fluid, from his right hemithorax. So I thought, this is fascinating. And as it turns out, when we asked him, he said, yeah, just before the pneumonia, he had this really bad, sharp pain in his right rib, no trauma. And then he developed this pneumonia, was admitted, and then subsequently got better. So we thought, this is very interesting. So what we did is we then applied some of the fantastic AI tools of your AI tools, and found out that the guy was severely osteoporotic. No history of this, never been found. We found out he was terribly osteoporotic, which explained an atraumatic fracture of his right rib, which interrupted his neurovascular bundle, dumped 4 liters of bloody fluid into his right hemithorax, and was called pneumonia. None of this had been put together before. And during this whole hospitalization, no one had come up with the idea that this guy actually had severe osteoporosis as the initial instigator of an entire clinical journey for this poor guy. And in addition, another thing we found using some of the AI tools that you have is we found out he had severely elevated chamber sizes, both his LV and RV. And in fact, during his time of pneumonia, quote pneumonia, he also developed atrial fibrillation. So we then applied your chamber volumetry AI technology to his case, and found out that he had both LV and RV enlargement, and also left atrium, right atrial enlargement, and severely increased LV mass. This led to an echocardiogram, which had not been done before, and we found out he had both severe TR and MR as well. And it's just fascinating. I've always been fascinated by all the, as I call it, the free data that we can extract from cardiac CT. And now with the validation, with the AI, being able to apply this to our patients in a quick, easy, fast way, and then validate it, and then also being able to create these percentiles, so we can then determine where this patient falls on a variety of percentiles, from bone density to chamber sizes. Your AI technology added to his cardiac CT information was dramatically effective to really piece together a pretty puzzling clinical pathway, and we're able to both later attend to his metabolic bone disease, and also be able to attend to his valvular heart disease, all from one single scan, coronary CT scan, and then derive all this additional free data. So there's kind of where the rubber meets the road, and I think we're going to be really caring, particularly when the rest of the portfolio of your AI is cleared by the FDA. I think it's just going to be an incredible way to diagnose so many interrelated conditions, from myosteatosis, metabolic syndrome, valvular disease, risk for AFib, diabetes, prediabetes, lung diseases, and even osteoporosis. So back to you, Mort. Thank you so much
Thank
for
you
this,
so
these
much,
fantastic
John. That
tools.
was great. This was a surprise. I didn't see this before. Thank you. I'm going to take the screen back. If you could stop your sharing, and then bring us to the one who has done the most in our team actually using this AI on this panel. That's Tom Atlas. He is, as he introduced himself, a practicing radiologist, and he oversees several imaging centers, which I envision they are early adopters and innovators, but hopefully 10 years from now, there will be thousands of those preventive imaging centers. That's, I think, functionally. So, Tom, with that, I pass it on to you to tell us about your experience and how you see it going forward.
Yeah, I think you guys hear me okay? Voice is good?
Yes.
I think the two things that seem to come up on the calcium score side when we're doing the screenings, number one would be, the patient gets the 0 score or low score, and then they have a heart attack the next week. And that happens like once a year. And so I think that one should be able to be picked up, hopefully, right, with the new Agatston 2 and the AI-CVD. And then the other big one that happens frequently are the people with they have a high score, they go back to their cardiologist and go on statins, but they still want to get another scan and they want something to follow up just to see how they're doing. And so they'll come back, and then that develops a little conflict sometimes with some of the cardiologists because they're saying, why are you doing a CAC scan if he's already on statins? And we've developed sort of ad hoc systems, using various articles, we try to, count the plaques. We use the plaque volume, we can tell them, if your score is relatively stable, but your volume's changing, it means, maybe that's a little more risk and stuff like that. But I think having all-in-one package like Agatston 2 is going to speed things up a lot. And also, I think it'll be a lot easier to convince the referring cardiologist once you have a system, that's the new guidelines. But as far as like using the actual tools, I really like the AICVD. The two big ones, right now that we're using are the BMD and the auto chamber. And I think the auto chamber seems unusually popular. I thought it would be popular, but I didn't think it would be accepted so quickly. And it seems like even when we add it on without talking to the cardiologist first, and we just since we have health coaches, I'm kind of lucky in that sense. If someone comes in for a screen, as they're in the waiting room, we'll meet with them and just say, look, we're doing your CAC scan. We can also give you a little more comprehensive evaluation of your heart with the auto chamber and tell you about your chamber sizes. And then we have a little thing we explain to them. So they'll oftentimes get the auto chamber and then they take it to the cardiologist. And we've had like no negative feedback. And that's been several months now. We've done quite a few of them. They seem actually pretty happy with it. And we're picking up a lot of stuff. And I think, maybe the reason that they're accepting it so much is that at least in California, the delay in getting an echocardiogram is really long right now. So if they can get the CAC score and then they come back and they've already got the chamber volumes, they seem pretty happy with that. And then if they want, they can look at the valves and do the echo and all that later on their own. So yeah, it's been really popular. BMD, same kind of thing was alluded to earlier with that Dr. Osborne's case, right, where you picked that up. But fortunately, we can process them really quick. So if they get like a lung cancer screen and I'm looking at it and I see the bones look a little osteoporotic, or if it's a male with a compression fracture, we can ask them, do they want to run the BMD before they even leave? And so we've got their approval, and then they get an osteoporosis report. And that's worked out really well.
Thanks,
I'm really
Tom.
happy.
So what you just said, like early days, like we're measuring LDL or HDL, hopefully we will have a panel, like lipid panel. This whole package would be, it's like metabolic panel that we ordered in clinic. This would be the imaging version of that and build on it. But that's the work that we will have to build. As I said, we've published now close to 10 papers on this, and more is coming out. With that approach, I want to just wrap up the discussion by Tom actually summarized it very well. He said basically we had two things with Agatston 2.0. One is we identify that once a year call that he gets of people who had CAC 0 and had events. And then the other is monitoring density change, especially low, high over low density. And that's what Arthur specifically asked us to look into it. So with that approach, now how do we see the future? As you all know, we have a symposium, unofficial American Heart Association's satellite symposium that we invited luminaries to discuss what we internally refer to, David, Claudia, and Tony, and some others weighed in, of a proposed study design that would evaluate these in a very large cohort and basically set the stage for the future. So I'm going to ask David to weigh in a little bit and then go around, ask Arthur and others. David?
Well, I think this kind of a trial, to a large extent, is going to be highly useful in sort of convincing, the world really about the value of all these tools. I mean, I think they'll gradually get acceptance as we're going, but a trial like this has the potential to really solidify it. Many times, innovations require something more than just, papers and whatnot. It leads to slow uptake, and guideline agencies won't fully accept it. So a trial like this, I think, is going to be something very exciting. We're really looking forward to participating in this and, working out the most efficient and comprehensive type of trial, because ultimately this is going to lead into what we think of as a comprehensive evaluation. This is going to become the future of preventive health. That's what we think. And while it may not seem like it, we're still just scratching the surface of the type of information we're going to be extracting. This is going to continue to increase. And it's already, I think, surpassed what's available. So very excited about participating in this.
Okay, great. Thank you, David. Arthur, would you like to weigh in? We're going to wrap up the discussion with your summary of the field, 35 years, and how you see it in the next decade.
Sure. As everybody else has mentioned, I'm just super excited by all this. And certainly, with this new study, there is a lot of specific data, not so much, the theories, but to give us endpoints. And one thing, when we first did in 1991 a 1-year follow-up of our original patients, every time I saw a new lesion, and this was all manual, of course, 130 Hounsfield units, that was the threshold for calcium used in radiology at the time. I could see a subthreshold lesion. So, well, why not just decrease the threshold? There was too much noise. So my two problems were, the good news is I could see definitely lesions at lower calcium thresholds, Hounsfield unit thresholds, but it introduced too much noise. And with your new application, you can look at lower density by the patients becoming their own controls, and you're getting rid of the noise. So those are two things I saw early on, but I had no way to go forward with it. And so this is all very exciting, and it's so much less expensive. We can do new things with MRI, with all the chambers and quant and all different areas, but it's very expensive. And this is really going to be available to the general population. So with the cost, and then And with the new trial, I think that what you're seeing is literally the age of the lesion. And younger plaques are new, the more dense plaques are older and stable. And so, discovering the exact numbers that tell us really how old an individual plaque is and how many younger plaques, less dense plaques there are, then I that's going to be just a huge addition. So we'll be able to, I call it the way you carbon dated, fossils. We're going to be able to date the individual lesions and know how old they are and how stable or not stable. A lot of young lesions means that they're still progressing and you haven't treated them aggressively enough. And that we do in our practice every day. And so people, for all kinds of reasons, they're still forming new plaques. And those are the ones you have to treat more aggressively. And we do. And so that's going to be just a huge addition to tailoring aggressive therapy to the ones who really need it, and the ones where everything is stable, you'll know it.
What I think is amazing about this trial, which really makes it very promising to succeed, is that you have multiple targets. So you're not just targeting people with coronary calcium, but also people with increased chamber sizes, myosteatosis, also bone density issues. So with multiple therapies, right? So it's really taken the Rubinska trial, which, is being done in the Netherlands and will hopefully report out in the next year or two. It's taken it several steps beyond that. So I'm very excited to see this move forward. And I think, as Arthur said, this is going to be done at much lower costs because you're not having to, rescan people, but you're opportunistically examining these issues in people who already have existing scans. So it's great potential you have with this trial.
Thanks, Nathan. The paper that you were part of, official statement from American Heart Association, put also a new light into this, that this is a low-hanging opportunity for early detection. I said it before, it's really striking that we do so many CCTA, for example, today, probably close to 3 million, and nobody reports chambers volume in these patients. Nobody reports any of these items because this is not just for non-contrast. It works for CCTA as well. It works for non-gated and regular long scan as well. So we should try to bring all of us together to evaluate this. So that trial is really the cornerstone, as David Yankelevitz puts it, the opening of a new era of preventive health. If we develop this, this is not just going to be for cardiologists. It's not just going to be for pulmonologists or cardiometabolic. It will have lung cancer in there. It would have the entire, pretty much 70-80% of mortality. So with that conclusion, that we plan to have that, we will have another recording at the American Heart Association meeting in New Orleans with this trial. I want to thank our panel members for their time and for their decades of tireless research and devotion that made this presentation possible. This AI, again, this work that we have done sits on the back of a tremendous amount of work that Arthur, John, David, Claudia, Nathan, and many others have done that made it possible, and all those people who did the Framingham Heart Study and the MESA study, because without those, we wouldn't be able to apply this AI 30 years back and get these wonderful results. So thank you very much for your time. We hope that this education, this is again, was to raise awareness. Some of these items, as John and Tom mentioned, are not available in their practice. Hopefully FDA will release those, and we will be able to build the evidence very convincingly for all of these. But I think we have now, with Tony's presentation, demonstrated that Agatston 2.0 is ready, and we should be able to get more information on those and expand it hopefully to patient care. So with that, thanks so much for your participation, and thanks to SCCT for giving us the opportunity to communicate with its members. Thank you.